Okay, I think we're good.
Okay, it says we're recording. Hi, everybody. Thanks for joining our seminar. I'm Lisa Barrow at the University of Colorado Anschutz Medical Center. And I'm very happy today to introduce the first speaker for our joint seminar program between the Rocky Mountain U.S. Cochrane Network affiliate and the Colorado Evidence Synthesis program. And we formed the Colorado Evidence Synthesis program because we really are branching out into areas where evidence synthesis has not been traditionally used. And I'm delighted to introduce our speaker today, Dr. Nick Chartres, who is become a real expert in this area. So Nick has a background in nutrition, and he has a PhD from the University of Sydney, where he studied bias in nutrition research, as well as bias in the process for developing dietary guidelines and other types of public health guidelines. And this actually led him during his PhD to have a stint at the World Health Organization, where he looked at different methodologies that international organizations were using to do environmental hazard assessment. And so following his PhD, he's really shifted into this environmental area. And Nick is now the Associate Director of Science and Policy at the University of California, San Francisco, with the program on, if I can get this right, reproductive health and the environment. And so Nick's going to talk to us today about the evolution of evidence synthesis methods in this environmental health area. And we will have time for questions at the end. And if you have questions, you can also type them in the text, and I'll be monitoring that. So Nick, over to you. It's great to have you.
Yeah, wonderful. Thank you, Lisa. And good morning, good afternoon, and good evening to everyone, depending on where you are around the world. I'd like to start by taking the opportunity to thank Professor Lisa Barrow for the opportunity to talk, also to Assistant Professor Nina McHale for all her help in coordinating today's talk, and also Ellie this morning for helping with my slides. I may, just for the sake of bandwidth, stop my video whilst I'm presenting. But if anyone has any questions as we go, please feel free to use the hand function, and I can stop and answer any questions. And as Lisa said, I'm also happy to take them at the end. So I might just stop my video. But you still should be able to see my slides.
Yeah, wonderful. We can see the slides.
Yeah, great. So before I start, I just would like to say that I have no conflicts to disclose. And importantly, I think before jumping into the topic of evidence synthesis methods in environmental health, I just want to give you a bit of context for today's talk. Lisa touched on the fact that I'm here at the program on reproductive health and the environment at the University of California, San Francisco. And I think an important place to start is understanding the mission of our program's work, which you can see there on the screen, which is to create a healthier environment for human reproduction and development by advancing scientific inquiry, clinical care, and health policies that prevent exposures to harmful chemicals in our environment. And I think it's really important to understand that our research as a whole, as a program, illuminates how chemicals can harm health, but also how we can promote evidence-based actions to prevent such harms. And that's obviously going to tie into a lot of the work I do talk about today. We do that through internal and external partnerships. We have a multi-pronged strategy to transform environmental science to improve public policy. We do it through, one, producing the best science. We produce a lot of research. We have a research arm. We bring the science to decision makers through direct engagement and communications. I do a lot of work in the policy area. As Lisa said, I'm part of the science and policy team. We engage with scientists and health professionals and leaders in promoting better policy. So we try to make that science actionable. And we also develop innovative tools to harness the science to prevention-focused decisions in clinical and policy arenas. And certainly systematic review methods and evidence synthesis methods are part of that. One other thing I think it's important to touch on, we're heavily engaged in how the US EPA implements the Toxic Substance Control Act, and also how the US EPA is involved in rulemaking. I'm going to use examples today around some of the work we've been doing related to evidence synthesis, but with the focus and the lens on the work at US EPA. So just, I think that's an important thing also to highlight. Oh, going the wrong way, not a good start. So I think it's important to set the stage, and I'll turn your attention to a recent paper that was published that talked about the estimates of chemicals that are currently in our environment. And there are over 235,000 chemicals currently registered. And there's 120,000 without registration. So we're looking upward of 350,000 chemicals in our environment. But this illustration frames another layer of the problem, which is the fact that we don't know the toxicity of a number of these chemicals and how harmful they are to human health. So whilst we know there are a lot of chemicals out there, very few are being tested. This slide here adds another layer of complexity. This is about the production and volume of chemicals in the environment. So whilst we have obviously that hundreds of thousands of them, we're also producing hundreds of thousands of pounds each year per person. And as I said before, though we have some rigorous research characterising the effects of some chemicals, again, we have this big gap. We don't know the impact of a lot of these chemicals. And obviously if they're so ubiquitous and also being produced in such high levels, it's obviously very concerning for the human population. And this figure illustrates, I guess, the magnitude of the problem across an extensive time horizon. And the y-axis here indicates the historic relative production volume. And in 2017, you could see that production volume had increased by around 15-fold from back in the estimates of back in 1945. And these chemicals are in several consumer products. You probably all know them. Polyfluorinated compounds used in Teflon and cookware, polybrominated compounds that we see in flame retardants in furniture, phthalate diesters incorporated in lots of plastics and baby toys, and also phenolic compounds that constitute the several food container materials that you probably use in your house. So again, they're ubiquitous and they're increasing. And compounding that fact of the concerns that we have around these chemicals, we're seeing increasing trends on the health harms of these chemicals and how they could be influencing different health outcomes such as leukemia, asthma, and also autism and ADHD in children. We've seen these increasing rates over the last few decades concurrently with these increasing production of these chemicals and also the development of new chemicals that are entering the marketplace as well. So my slides are stuck, 1 second. I don't know why it doesn't want to turn. There we go. Apologies for that. And as we know, evidence-based policy actions have reduced major gains in health and reaped associated cost savings. We can think about examples from tobacco control, lead poisoning prevention, also programs to reduce pollution, which many of us know about. But conversely, taking or failing to take timely action on scientific discoveries obviously prevents opportunity for us to prevent harm to the human population. And so we need robust methods to synthesize what's known about environmental drivers of health to make science actionable, which is what I talked about, what our program does at the top of today's talk. And I'm sure many of you know, been part of, I guess, Cochrane, the role of expert reviews that have previously informed clinical decision-making began to be questioned throughout the 1970s, and we started developing more transparent, rigorous, and systematic approaches, which used explicit methodology to evaluate a body of evidence to answer a clearly defined question. And we started developing what we now know as systematic review methods. And these obviously over the past 30 years have been used extensively in clinical science, in clinical research. And there's been this gradual evolution of the methods and refining of these methods through empirical testing by the Cochrane collaboration, also by grade. And we also now have standards. Obviously, Cochrane has a set of standards, MSIR, but also you can see here on the screen the Institute of Medicine, which the standards that we know are critical for implementing and ensuring that a high-quality systematic review is conducted. And for those of you who don't know what the definition of a systematic review is, because again, often it's an assumption that people do know what it is, I've just popped it here on the screen. It's really important, I think, to ground today's talk in it, because I'm going to focus a little bit on this specific method. And it's a method that identifies, appraises, and synthesizes all the empirical evidence that meets pre-specified eligibility criteria to answer a research question using explicit systematic methods that are selected with a view aimed at minimising bias to produce more reliable findings to inform decision-making. And I'm going to talk a little bit about the regulatory context in the US and I guess how systematic reviews have failed to achieve that. So until very recently in environmental health, you saw this on the introductory slide, research synthesis has looked a lot like this. It's been based on expert narrative reviews that don't follow these pre-specified and consistently applied transparent rules. So it's very difficult, or it has been very difficult, to know if all of the available evidence had been identified and evaluated consistently to answer specific questions related to environmental health. And also the decisions that were being made in the review processes were not documented, such as what studies to include or exclude, and how the risk of bias or the internal validity of a study was being evaluated, and how the results of the individual studies were being combined to come up with a conclusion to answer a specific question. So a little bit haphazard. But there was a reason for it, and it's the fact that whilst there are a lot of fundamental, there's a lot of fundamentals at the university of both clinical science, systematic reviews, and also those used in environmental health, which we're going to look at in a moment. There are some critically important differences which, prevented the uptake or the development and the adoption of systematic review methods for environmental health that you can see here on the screen. Firstly, the types of evidence being summarised. Within environmental health, we have a broader range of evidence to consider, such as observational human, experimental animal, and also in vitro study designs. And importantly, they're designed to elucidate disease etiology and identify health risks. And that's opposed to, I guess, the evidence and the methods for treatments for disease using a body of evidence or effectivenesses of interventions, which are typically used in the clinical sciences, which can rely on randomized controlled trials more readily. And so we don't typically have the availability of that type of evidence in our type of evidence synthesis. The other thing to consider is obviously if we have these different streams of evidence, so that the human, the animal, and the in vitro data, we have to think about how we integrate that evidence. And it's an additional step, an additional consideration that perhaps limited the immediate uptake of these methods. So in 2009, we recognised the need for a similar, transparent and consistent approach to evaluating environmental health evidence to support clinical and policy decision-making. We established an interdisciplinary international collaboration. So the navigation guide was developed in part by the University of California, San Francisco, led by Tracy Woodruff, and then a range of other environmental health scientists from academic, government and non-government organisations. And they essentially incorporated the best practices in systematic review and research synthesis from the clinical sciences into the field to make sure that we were advancing evidence synthesis like the clinical sciences had been. And as you can see here on the screen, that obviously included adopting and adapting methods from both Cochrane and also from Grade. And just to give you an understanding, in terms of the actual steps and how, I guess, the processes deviate, across the arrow there, you can see the steps for an environmental health systematic review, and they're very similar to what you'd typically see being implemented within a clinical systematic review. I guess there are four key differences. I've already touched on a couple of them. The first one you can see there, we use what we call a EPA Statement. So we're interested in looking at populations exposures as opposed to interventions. We still look at comparators and outcomes. When we consider the risk of bias or internal validity, we use different tools. Again, depending on whether we're looking at observational human data or animal data, we use different tools to the tools that are used for randomized controlled trials. We also assess the quality of the evidence differently, or depending on the method that's been applied, you can assess it in a different way. Typically, observational data will get downgraded as opposed to when using randomized controlled trials, when assessing the body of evidence, a body of evidence that only including randomized controlled trials will start at a high level. And then you can see at the top there, environmental health systematic reviews can incorporate 3 streams of evidence, where again, in the clinical sciences, you only have that 1 stream of evidence. Just put a little note down at the bottom, which I'm going to cover a little bit later, which talks about the methods that are used for risk of bias, but also assessing the quality of evidence, and how these methods can certainly change the overall rating or evaluation of the evidence. And that certainly does have an impact then on how recommendations are made, and then how policymakers consider those things. So for the navigation guide systematic review method, for the risk of bias step, we consider very similar domains to the risk of bias tool that is used for Cochrane. We have a couple of additional domains. I think an important one there to highlight at the bottom is financial conflicts of interest. We then assess the quality of evidence in a very similar way. We have a number of things whereby we can rate the evidence down based on risk of bias, indirectness of evidence, inconsistency, imprecision, publication bias. And then we have 3 factors that can elevate or increase our confidence in the body of evidence. But again, important to note when using the navigation guide, when we take observational studies through that step, we consider them at a medium quality as opposed to a low. And then finally, we have a step whereby we make a statement around the strength of the evidence. We have additional considerations there. So again, it's very similar in terms of the processes. There's just a couple of important fundamental steps that deviate, and they are certainly important to understand. And that's what I'm going to talk about more today as I go through the presentation. Just to ground you in terms of, I guess, the evolution over the last decade, I talked about the systematic review method being developed here at UCSF by Tracy Woodruff and other collaborators. There has been certainly other groups that have been evolving systematic review methods over the last decade. You can see here on the timeline on the left-hand side, when we first published our navigation guide back in 2011. At the same time, the National Academies of Sciences released a seminal review on the US EPA's Integrated Risk Information System, or the IRIS program. For those of you who don't know what the IRIS program is, it has been the leader for hazard and also hazard identification, hazard characterization within the agency over the last few decades. And over the last decade, they've been evolving their methods based on the NAS's feedback on their methods to become more consistent with best practice in systematic review. And that started back in 2011. You can then see in 2013, the National Toxicology Program and Office of Health Assessment and Translation, they also published a systematic review method. And that method was partly informed by our navigation guide method, and their method is very similar in terms of how they consider risk of bias and also how they rate the body of evidence. So there's a lot of similarities between the two. I think importantly, once our method was established, we then went on to demonstrate the feasibility and robustness of this methodology through 6 proof of concept case studies across various topics. And we did that in collaboration with US EPA, California EPA, and also the National Institute of Environmental Health Sciences. And you can see between 2014 and 2017, we actually did 6 different case studies on different topics. So I'm going to talk about one of those a little bit later today. But we've also just published a final systematic review looking at the association of formaldehyde on asthma. A couple of other important things just to note on this timeline. You can see there in 2018, the US EPA, they, under the Toxic Substance Control Act, which has been implemented by the Office of Chemical Safety and Pollution Prevention, they developed a systematic review method to evaluate the evidence. And that was because back in 2016, the Toxic Substance Control Act was amended by Congress. A new law was passed to essentially evaluate chemicals that were currently in production and in use, and they've been doing a prioritisation process over the last 4 years, evaluating the first 10 chemicals, and we've been weighing in on that. And I'm going to talk again a bit about how that's been conducted and the implications of their systematic review method on those evaluations, and then probably the more broad implications for public health. And finally, in 2019, you can see down there, that highlights a couple of things. First of all, the International Agency for Research on Cancer, so IARC, they began incorporating systematic review principles into their updated preamble. But importantly, the navigation guide method was used by, and it's still being used by, the WHO and also the International Labour Organization to conduct a series of systematic reviews to help WHO and ILO to develop joint estimates of the global burden of work-related disease and injury. And they're looking at 10, and they are still looking at 10 different occupational exposures with various health outcomes. And this was quite a groundbreaking project based on the fact that there have been over 200 experts globally across 35 countries that have been involved in that project. And so what it's seen the navigation guide method, the systematic review method developed here at UCSF, broadly taken up by WHO and used by this group of experts. And this is one very important study that was recently released just 2 months ago which was looking at the association of long working hours and ischemic heart disease and stroke. And what it found was that for the first time ever, identified the number of people within the world that were working more than 55 hours per week, and then what the health implications were for that. And it was found that there was a 17% increase in the risk of heart disease and a 34% increase risk in stroke for anyone that was working over more than 55 hours per week. And they also found that around 9% of the global population works more than 55 hours per week. And it's now been established that this is the #1 burden of work-related disease globally. And importantly, it was due to the fact that the navigation guide systematic review method was used to synthesize that evidence. And there's more, like I said, reviews coming out in the future. So what does that mean? So I talked about the timeline of these systematic review methods being evolved by a number of key organizations within the US. I've talked about the fact that WHO, ILO have picked it up and they're currently implementing it. Lisa mentioned at the top of the talk that I did a review, actually did it with Lisa a couple of years ago, and we looked across 14 different organizations that are doing hazard identification and risk assessment. So essentially doing what the US EPA are doing under the Toxic Substance Control Act. And we looked at these organizations across the world, and we wanted to look at their methods broadly, but also specifically in and around how they are conducting systematic reviews. And as you can see here on the screen, across the 14 organizations, we only found one group, which was the National Toxicology Program's Office of Health Assessment and Translation, who I mentioned before, that actually met all 11 of the AMSTAR items, which is a systematic review tool that is used to assess its quality. And out of the other organizations, there were 5 others that said they actually conducted systematic reviews, but their methods did not meet the standard of the AMSTAR. So for us, that was a really important learning to understand that whilst there was this development, and whilst certainly in the US, there were some key organizations moving towards their use, there was obviously inconsistencies across the world in terms of its uptake, but also importantly, that a number of the methods and the processes being used by these organizations weren't empirically based, and that there was a real gap and a real need to further develop empirical methods to ensure that we're getting a consistent implementation of systematic review methods consistent to what we see in the clinical sciences. We then went and conducted another systematic review, another review of systematic reviews, but this time, instead of looking across other organizations that were conducting hazard identification risk assessment, we did a comparison of systematic reviews versus narrative reviews. So I mentioned when I was talking about the evolution of these methods that for a long time and even now, evidence synthesis is still, narrative reviews are still used for evidence synthesis a lot in environmental health. So that's what we wanted to compare. We wanted to see, was there a difference across these 9 different domains of a tool that have been developed to assess the quality of a systematic review in environmental health, and see if systematic reviews were outperforming narrative reviews, which you hope would seem logical that they would, because you're hoping that systematic reviews that have already been published are at least embodying some of the key things that we know are critical to a valid and reliable systematic review. So what did we find? We found 29 reviews, and you can see them all here on the screen. There was 13 systematic reviews and there was 16 non-systematic or narrative reviews. And across every domain that you can see there, the systematic reviews received a higher percentage of satisfactory ratings compared to non-systematic reviews. So across the board, they were typically better. And we found certainly across every domain that the narrative reviews, in only one domain, they only achieved more than 50% in terms of a satisfactory rating, and they performed very poorly. But what we were concerned about was that across 8 of the domains, across 6 of the domains, there was systematic reviews failed to achieve over 50% in terms of satisfactory rating. So 50% of the systematic reviews couldn't get over 50%. So there was a real gap again. So they may have been outperforming narrative systematic reviews, but in terms of the consistency of the methods and the alignment with those empirical based methods that we've seen in the clinical sciences, there was certainly a really big gap. So I guess, again, what does all this mean from a public health perspective and a real world perspective? Well, as I said before, a lot of our work over the last couple of years has been looking at how US EPA has been implementing the Toxic Substance Control Act. And as I mentioned before, they developed this method, which you can see on the screen, which is their handbook, back in 2018, for basically how they're going to go about conducting systematic reviews for evaluating the chemicals that they need to evaluate the chemicals that are under their jurisdiction. And they had a definition for what a systematic review is, which you can see there on the screen, and it sounds pretty consistent to what I read out earlier with the Cochrane definition for a systematic review. But what we saw in terms of its implementation was very similar to what I just showed you before on the screen with the narrative reviews or even the systematic reviews, was that whilst the term systematic review has been used, that certainly the standards that we would expect for a systematic review weren't being met. And there were some critical differences, and they were leading to a gross underestimation of the potential true risks of these chemicals. I'm going to show you those in a moment. So on the left-hand side here, you can see that these are the key steps for conducting systematic review. We expect to see a scoping step, broad literature search and problem formulation, certainly the development of protocols. When we're identifying the evidence, we want to make sure that it's across multiple databases, that all studies are being clearly labelled, and they're also being included and excluded from the evaluation based on pre-established criteria. When the evidence has been evaluated, we'd obviously expect to see a tool that has been validated and it's consistent with best practice. And also when we're integrating the evidence streams, we'd also expect to see those methods for how that's going to take place being predefined. But what we saw with the TOSCA method across every single risk evaluation was that essentially none of the key steps from 3 through to 6 were being conducted. So not one systematic review that was conducted for the first 10 chemicals had a protocol. Across every single systematic review that was conducted for every chemical, there was evidence that was either missing or there was not a clear inclusion-exclusion criteria published before the searches were run. When they went to evaluate the studies, and we're going to look at an example in a case study a little later, they used a tool that had over 22 metrics, I think of metrics like domains, and across the majority of those, so 17 out of the 22, a study could be excluded for one simple flaw, and a lot of evidence was excluded because of one simple flaw. And across every single systematic review for the first 10 chemicals, there was not one that had the method for how they were going to integrate the evidence or come up with the overall hazard identification conclusion predefined before the review took place. So they essentially broke every single rule that you'd expect to see in a high quality, reliable, systematic review method. And we were commenting on that, and we did that for every systematic review that was conducted for the first 10 chemicals. So what does that mean? Again, if we think about this, and I'm sure many of you are familiar, you may have even seen this picture before, if we're not capturing all of the key evidence and then using the appropriate methods to evaluate the evidence, the systematic reviews that are underpinning these public health guidelines or these risk assessments essentially crumbles. And so the conclusions of these first 10 risk evaluations have been significantly impacted, and they are certainly scientifically flawed based on the fact that this method had these very concerning flaws within the method and how it was also implemented. US EPA is currently going back to open up 7 of the 10 risk evaluations. I'm going to talk a little bit about what they're doing with their systematic review method moving forward in a moment. But the first 10 risk evaluations that have been conducted are unfortunately scientifically flawed. And that obviously has huge implications for public health because these chemicals will unlikely be re-evaluated again, if ever, or for for several decades. The other current handbook that I mentioned on my timeline or program that's been that is critical to US EPA and its function is the Integrated Risk Information System, or the IRIS program. And I mentioned that back in 2011 that this program was being reviewed by the NAS, and over the past decade, they've certainly been working towards integrating more systematic review methods that are certainly in line with best practice. And they've done a fantastic job, and the NAS has done reviews back in 2014 and also back in 2018 to track how they're going. This program is now currently under review once again by the NAS. And it has additional weight and importance now because obviously there's been critical flaws that we've identified within the US EPA TSCA method that's been implemented or used for the evaluation of these chemicals under TSCA. And we're certainly recommending that US EPA looks to the IRIS program because they embody a lot of those key fundamental principles of a validated, reliable, systematic review. So the NAS is currently reviewing it, but there is, again, some concerns that we have around the systematic review method. You can see 3 of them on the screen there. The first one is that it uses an overall risk of bias rating, and it's confusing and a little bit ambiguous. Number 2, it excludes studies based on only one deficiency or critically deficient domain. And then finally, they don't consider financial conflicts of interest. We know that there's a lot of empirical evidence supporting that as a key risk of bias. So why is this relevant and important? Well, when the IRIS program is evaluating primary studies, the way this tool operates and functions, it can eliminate a large body of evidence. And you can see here on the screen on the left-hand side, it talks about the fact that low confidence results are generally not used for hazard identification or derivation of toxicity values. Now, for a study to get a low confidence result, it simply only needs to get one deficient rating across 7 domains you can see there on the screen. And then the overall study is rated low confidence, and it can be removed. It isn't considered for hazard identification. And so that's deeply concerning when we're thinking about what the implications may be for a body of evidence, particularly if it gets in the wrong hands. So if there's a change of administration and there's any type of undue influence on the process, certainly there can be real ramifications for how the evidence is evaluated. And it can then be justified and said that it's based on the fact that there's this scientific method that's been used for many years. So that's our concern with this method. You can see at the bottom there also, it only takes one critically deficient rating in one domain for the entire study to be completely removed. So we have been commenting on this as well, and we're obviously interested to see what the NAS report says on this method. The reason why I'm telling you all of this is that these are the key issues that we think obviously have a huge impact or potential impact on how protective the decisions and conclusions that are made in risk evaluations are for public health. And instead of trying to explain it in a presentation like I'm doing now, which can be quite difficult because some of these ideas and constructs, particularly the risk of bias, are new, we went about and conducted a study to demonstrate this and show what the real life impacts of using tools that aren't validated or consistent with best practice to show what the impacts are on a body of evidence and therefore public health. And this is the study that we've recently published. I'm going to step you through that study, and I'm going to use the examples that I've just touched on. So the tool that's used for the assessment of evidence in the risk evaluations being conducted by the toxic substance, US EPA under the Toxic Substance Control Act, but also talk about and show how the IRIS tool evaluates a body of evidence. So just quickly, for those of you, again, I'm sure many people do, but for those of you who don't know what risk of bias is and what I'm referring to, it's essentially looking at the characteristics of a primary study that can introduce systematic errors in direction and the magnitude of the results. And it reflects basically how a study has been designed, conducted, and analysed, and it's very different to reporting. And we have a tool. This is our risk of bias tool, and it's based very much off the Cochrane collaborations. I think it's now called the 1.0 tool that was developed many years ago. We attempt to look at the same types of biases across the study. There's obviously slight differences. We obviously don't have randomization in our studies, but things like exposure assessment, outcome assessment, incomplete data, and select outcome reporting are all very similar. So that's how we evaluate the risk of bias in our systematic reviews when we're conducting them. For the National Toxicology Program, Office of Health Assessment and Translation on the left-hand side there, they use a very similar tool to us. So they essentially use similar domains and they apply it in a very similar way. So the methodology doesn't deviate significantly. On the right-hand side there, I tried to describe this to you before. This is the risk of bias or the study quality tool that US EPA was implementing to evaluate the studies under the Toxic Substance Control Act. And as you can see there are 22 metrics, so essentially 22 domains that they consider. They use a quantitative approach, so they add numbers. And again, like I said, across, I think it's 17 of the 22, if a study receives an unacceptable rating, so a 4, the entire study immediately gets removed. So there's a lot of potential for studies to be inappropriately evaluated. And I've already shown you the IRIS tool, so I'm not going to show you that again. So what do we do in this study? So we took those 4 tools and we compared and assessed the risk of bias using 15 studies that were previously included in a systematic review that we conducted, looking at the association between PBDE exposure, so one of those chemicals I mentioned at the top of the talk, and the reduction of IQ. And critically, this review that we have published, and it's available, you can go take a look at, the National Academies of Science has actually already used our review before as the basis for one of their own assessments. And they found that there was no evidence of risk of bias in our assessment. So in other words, we used this study or used this systematic review because we knew that it was empirically based and that we didn't have any concerns in terms of how the studies had been evaluated on our part and it had been adjudicated by an independent body like the NAS. So we took those 3 tools, we took the 15 studies that we used in this systematic review, and we went and applied them to see what it would look like at the end of the evaluation. And this is what we found. So this is the navigation guide, risk of bias judgments. You can see overall, the green is typically low risk of bias, the yellow is moderate, and then you can see there's a few high risk of bias ratings across the different domains. And critically, there's 4 studies that were used in the meta-analyses that was part of that systematic review that we conducted. And that meta-analysis itself was really critical to our systematic review findings. The 4 studies found this overall association between PBDE exposure and IQ. And without those 4 studies in that evaluation or in our systematic review, we wouldn't have had that quantitative estimate to demonstrate that, that harm and that effect. This is what the NCP OHAT assessment looked like when we applied the tool. So again, it looks very similar in terms of the domains, but also you can see the coloring is very similar again. A lot of green, a little bit more yellow, but again, pretty similar across the domains. Nothing that was obvious in terms of a high risk of bias rating that was concerning. And then for the IRIS program, you can see here that because of the way this tool works, I mentioned before, it has essentially a weighting system whereby if one single domain receives a low confidence rating, the entire study gets the overall rating of low confidence. And for every single study that we evaluated using the IRIS tool, it received at least 1 low confidence rating. So therefore, every single overall study confidence rating was either low or very low. And then for the risk of bias judgments using the Toxic Substance Control Act tool, again, you can see the red this time on the screen there on the right-hand side. There's a question within this tool, within those 22 domains, that is about statistical power. And it specifically asks whether they have established whether there is enough statistical power within the study. And if it's not identified as being correctly calculated, it receives a deficient rating. So for every single study that was included in our systematic review that showed the association between PBDEs and the decrement of IQ, every single study using the TOSCA tool was excluded. And again, it was driven by that one rating of statistical power. There's also a couple of other domains that received it as well. And the overall score essentially meant that every single study was excluded. So what does all of that mean? It comes down to the fact that the IRIS tool and the TOSCA tool, so these 2 tools that are currently being used by the US EPA, have an overall study quality metric, and it's driven by one single domain. And that domain in both tools isn't necessarily empirically based because there's not evidence showing that that should lead to this critically deficient evaluation and removal of a study. Importantly, we also have in systematic review and meta-analyses the ability to do quantitative assessments and evaluation of studies of concern when we look at things like industry sponsorship, or if we have concerns around exposure, we can do things like sensitivity analysis. So there's no need or reason to be excluding studies or evidence like this. But what this has shown, if we had applied these two tools, which, again, there is a high likelihood that the IRIS program goes and evaluates something like PVDs in the future, there is potential for the entire body of evidence, every study, so all 15 studies, to be excluded. And again, it's dependent obviously on who the review authors are applying it, but this is what the real implications are on a body of evidence and what the real public health implications are also. So it was a really important study to conduct, and it sort of gets at, again, the key issues that I guess we have currently at the moment in terms of the development of empirical methods that are consistent across each organisation that are applying them. And it certainly will give the public a lot more confidence in the evaluations that are being conducted. So a bit of an update for those of you who don't know, the NAS, or the National Academies of Sciences, Engineering and Medicine, recently released their report on the TSCA systematic review. So that handbook I showed at the top. And this was released back in February 2021, and they found that the method was not comprehensive at each step. It lacked objectivity. It had a lack of consistent approach for documenting the objectives or methods for synthesis and evidence integration. And they said the entire evaluation process is compromised across all of its elements. So all of the things that I was mentioning before, the NAS agree with. And then they made the recommendation that OPPT, so the Office of Pollution Prevention Toxics, which sits underneath the Office of Chemical Safety and Pollution Prevention, should step back from this approach. So they should no longer use it, and they should consider components of the OHAT, IRIS and navigation guide methods, so the methods that I've been talking about today, and that they could use these methods and incorporate them specifically into hazard assessment. Importantly, EPA came out and said soon after this review was released that they're no longer going to use that TSCA method that I've shown you today. What we don't currently know is what they are implementing. There's been, since the change of administration and since the change of this, or since the report that came out and this statement from EPA, there hasn't been a release of a new method. So whilst it's obviously reassuring that this method has no longer been applied, we still don't know what that new method is, whether it's going to be similar to the navigation guide or OHAT method, which obviously, from what you've just seen in terms of how the body of evidence gets evaluated, we certainly hope that is the case. Importantly, they came up with 3 recommendations around how the risk of bias should be considered in future evaluations. So again, looking at the example that I just gave you, they said there was no justification provided for weighting of specific metrics within the domains to create the overall quality score. They said do not exclude studies based on risk of bias, study quality, or reporting quality. And again, importantly, they said use established tools for assessing risk of bias and study quality, such as those developed by NCP, OHAT, and the navigation guide. So again, it was consistent with what I was just demonstrating to you then, that these methods aren't empirically based, whereby we exclude studies based on one deficiency, and that they obviously can lead to erroneous conclusions of the evidence. So the NAS agree with this, and obviously we're hopeful that the US EPA follows those recommendations. Before I wrap up, I just want to touch on, I guess, a final step of our navigation guide systematic review method, and a really important consideration for when we go from taking the conclusions of a systematic review and thinking about what we then can do to intervene if there are exposures of concern. We have developed, when we first developed the tool, a 4th step, which is essentially the development of recommendations, but that method hadn't been developed. We wanted to obviously test the other steps of the systematic review and the navigation guide, which we've been doing over the last decade with the case studies that I talked about earlier. We're now at a place whereby we're going to be developing an evidence decision framework, so we can develop concise evidence-based recommendations for prevention, which is based on integrating the results of the evidence evaluation, but along with other relevant factors that are important to decision-making, including things like equity, human rights, benefit, harm, and feasibility. And we recently conducted a review that you can see here on the screen. We conducted it with Dr. Susan Norris, who used to be the former WHO Guidelines Review Committee Secretariat, and also our research scientist here at the program, Dr. Max Orm. And they did a scoping review of all the different current evidence decision frameworks that are out there, both in the clinical sciences, public health, and also environmental health. And the idea was to look at what the different methods were to develop these frameworks, how the criteria within the frameworks were developed, and also how they're considered in the decision-making process. And we wanted to see if there are other things that were potentially missing that we really need to think about in environmental health, like environmental justice and certainly health equity and non-discrimination. So we're in the process of developing that framework and testing it. We think it's obviously a critical piece of it because obviously evaluating the evidence is only one step. And taking the next step and developing a recommendation is critically important. So what I might do, because I know I've given you a lot of information, I might stop there, say thank you, and ask anyone if they have any questions.
Yeah, thanks so much, Nick. And here we go. Am I unmuted? Yes.
No, I can hear you.
Yeah, now you can hear me. Yeah. And I'd love to give people an opportunity to ask questions. I don't see any in the chat, but you can please raise your hand or flash your video on. And, Nick, I just want to say that was so interesting to see your timeline of the uptake of systematic review methods in environmental health and the role of your program, because actually that's kind of light years compared to what it's been in clinical medicine. So really, even though you're quite critical, which I think is appropriate, there's been a huge amount of progress in the uptake of this method. So I see we have a question coming up. Yeah, it's about public health is invariably political. And I think, Nick, you'd actually have a lot to say on this with your evidence to decision framework. So how much impact have political and commercial pressures had in this area? And you might want to put that in the context of how EPA really sort of went off of traditional systematic review methods with this idea of excluding studies based on a single risk of bias rather than doing sensitivity analysis. So I don't know, if you can say much about those pressures.
Yeah, absolutely. Sure. Yeah, I mean, obviously, particularly in the context of the case study I gave around US EPA and its implementation of the Toxic Substance Control Act, there's been very well documented political interference. So it's not me speaking out of turn here, political interference in the process, but also there was a lot of industry influence in terms of the agency over the last 4 years. We had 2 coal lobbyists leading the agency itself, the Office of Chemical Safety and Pollution Prevention in the early stages had a former director of the American Chemistry Council. And so the methods themselves obviously were underpinned by industry. And if you have a background in evidence synthesis and understand what the empirical methods are and why they're so important, it's very easy to take a look at them and realise that they weren't developed to be public health protective and that they were very much developed so that evidence could be under-evaluated or excluded. It was done in a way whereby it was grossly obvious at times, and we highlighted that and we put that on public comment and record. What I think is really important are some of these small and nuanced things, and that's why I wanted to spend the time talking today about having tools that I showed you whereby it seems like they're trying to get at the heart of what the key biases are, and they seem logical that perhaps if there is this potential bias or deficiency in it, maybe we shouldn't be looking at or keeping the study in the evaluation. But when you look at I guess the downstream impacts of what that looks like on population health, you start to realise that it's critically important that we're using methods that are empirically based, that are public health protective, that are validated, and that they've been tested, and that we have this body of evidence. Otherwise, what will happen is if we get something like the method that was used under the Toxic Substance Control Act being embedded in EPA, because it's a regulatory agency and it's in the United States, other agencies across the world and other groups could quite easily pick this up, assuming that the US EPA is obviously implementing the best method. So there's a huge amount of there was a huge amount of concern around it. Yes, it was, I think, very much driven by industry influence, and it's very important. We hope now that we see a method that's going to be more consistent with some of the methods that I talked about today from NCPO hat, our method, Cochrane, and also what we see with the IRIS program, how it's evolving.
Yeah, and I think all the scrutiny from the National Academy of Sciences has helped, because it's allowed for a lot of this methodological detail to be dragged out and commented on in the public too, which I think
absolutely
is really super helpful. Are there other questions for Nick? I know it's a lot to cover. Ting King.
Nick, thank you for a very informative presentation. I mean, I was just thinking about the work we do as part of the Cochrane. When we looked at the rating of the strength of evidence in the summary of findings tables, more than half of them are low or very low confidence. So that's based on, a lot of randomized controlled trials, right? And for environmental exposure, you're dealing with even lower quality evidence. So I suppose my question is really, when you look at the risk of bias and how the decisions are being made, do you think we need to calibrate differently to, what will be, the ideal study design and all of that? And we may never get there. So that's the first question. And related to that is, decisions needs to be made regardless of the strength of evidence for a lot of times. So your experience really on making decisions when the quality of the evidence is very low.
So I'll break it up sort of in answer to your first question. Certainly it's a big concern, and why I touched on it briefly at the start. I didn't want to get too into the rating of the quality of evidence, but it's a really important consideration, because this paradigm that randomized controlled trials are at the top of the hierarchy for study designs, because there is randomization, and it minimises the baseline prognosis, the opportunity for baseline prognostic factors to bias the study itself. Therefore, every other study design underneath it isn't of the same quality. And I certainly challenge that based on the fact that, one, we obviously, we can't randomise people in our field of health for ethical reasons, but also there are a lot of strengths to the observational design study, the generalizability of the findings. So, the populations we can look at, the latency period, the time periods that we can follow people over, the number of exposures that we can measure, looking at things like the dose response to give us greater confidence in that study design. So I think there's a belief that there is these inherent biases, and therefore observational design studies aren't strong enough. We certainly don't believe that, and that's why we start the body of evidence at a moderate quality rating. We recognise that there is a potential for bias, but we certainly don't think it means that there's low quality evidence. I think also the important thing to think about is that, again, from a public health perspective, when we're developing recommendations or when we're putting an overall rating on the quality of evidence, if we're saying that things are low quality evidence, it's how that gets interpreted by policymakers, but also by the general public. And so I think we have to be very careful with the language that we use, and that we're better at explaining what some of that means. Certainly when there's gaps in the evidence, so we may not have a really substantial body of evidence to have confidence in it, and we come up with perhaps a low quality rating on the body of evidence because there's a gap. I think that needs to be communicated better, as opposed to the idea and act, certainly in environmental health, act when there is potentially gaps in the evidence and uncertainty. We don't want to wait necessarily to find more evidence if there is uncertainty, because again, it may be too late. We've been exposed to these chemicals for so long and these exposures for so long. So I think it is an important conversation to have around communicating what weak or low quality versus moderate quality or high quality means when we're evaluating a body of evidence, particularly from an environmental health perspective. Clinical sciences, I know, are a bit different, and you can have, you've got one type of study, and you typically can feel confident when you apply the risk of bias tool at what that rating may mean. But I think for us, we have to be very careful in terms of communicating what low quality may mean to policymakers.
I think the precautionary principle must figure in there.
Yeah,
too.
absolutely.
If you are dealing exclusively with harms, and people may accept a lower confidence or lower quality of evidence to protect someone, where if you're talking about efficacy of a drug, maybe not. I mean, to me, that's an interesting area that you can capture in this evidence to decision table you've been developing potentially. More questions for Nick? These are very, there's a lot to dig into here. So Nick, do you want to just say something? We have a lot of folks I know, some on this call, but definitely in this program who are very interested in nutrition. And just as a final question, do you want to draw any kind of parallels between the work you've been doing synthesizing environmental risk evidence and nutrition?
Yeah, I mean, you're essentially using the same study designs to develop the recommendations that go into be it a risk evaluation or be it into dietary guidelines. So the process is obviously very similar. And I think, that's another important consideration when people are thinking about what the recommendations are. I think, when we talk about nutrition, I'm of the thinking that, from my experience, that we don't want to use typically randomized controlled trials because they don't give us the ability to really look at the important health questions. When we look at dietary patterns and when we look at foods over long periods of time, that gives us the opportunity to really understand what the relationship on certain dietary patterns and clinical outcomes are. And I think we need observational design studies and we need to really value them to get that information, and we need to sponsor we need to fund more research to ensure that we can ask those questions. If we go towards this idea of using randomized controlled trials because they're meant to be of a higher quality, we're going to get very narrow questions looking at the efficacy or the benefit of single nutrients or single foods over shorter periods of time, which to me doesn't really help the nutrition field, because we don't eat single nutrients. We eat dietary patterns. We don't eat single foods, and I think it gives the food industry opportunity to really leverage that type of thinking to maybe look and study at certain constituents, say that they've done them in randomized controlled trials, so that they've got great evidence for them, and then stick them all over their food labeling. So I think in our field we've got to value them more. I think certainly in nutrition we need to value observational design studies more because otherwise we're not going to be getting the evidence we need to answer the questions that are going to protect public health, which is looking at dietary patterns and foods over long periods of time in diverse populations.
Great. Any parting last words for Nick? Great, Nick. Well, you have a lot of work to do to keep advancing this agenda, so I think we'll let you go. And thank you so much
Thanks,
for
everyone.
this presentation. Thanks again.
Thanks, Lisa.
All right, bye.